Good morning, everyone. Thank you so much. Thanks, Mahesh, for the kind introduction. Thanks to ANZICS and ACCCN for this invitation. ANZICS, in the world of intensive care, ANZICS ASM is probably one of the biggest platforms for any intensivist and more so for early and mid-career researchers such as myself. So I'm very grateful, I'm thrilled, and I'm excited to be here. Thank you so much. I have the unenviable task this morning of being the opening speaker on the opening day of such a large event. No pressure. Thanks, Mahesh. So I've been tasked with speaking about the evolution of critical care as a specialty in India, but also specifically in the context of critical care research. These are my disclosures, but really the most important one is the fact that my perspectives come from working predominantly in sort of an urban context in one LMIC. So I don't speak for all LMICs. I've worked both in the public and private health systems in India, but most of it in a very urban sort of a context. So my perspectives also therefore come from a relative space of privilege, and I have to acknowledge that. All right. So this is sort of what I wish or hope to cover in the next 20-25 minutes. I'll talk a little bit about the healthcare system in India, the origins of critical care as a specialty, a little bit about the challenges of doing research, and how we've evolved in the last 2 decades or so, and where I think we should go next. So the healthcare system in India, for those of you that are not familiar, is a tiered system. There is a primary, secondary, and tertiary level of care. And health is a joint responsibility of the federal or the central government and the provincial or the state governments. Although healthcare spending in India has increased, it's still only 1.35% of our GDP. And if you're looking at intensive care itself, it's obviously very much in the tertiary end of things, both in the public system as well as in the private profit and not-for-profit systems. Who pays for health? In terms of the total health expenditure, 1/3 of the funding comes from the central federal government and 2/3 comes from the provincial governments. Public hospitals offer free, but not really. It's taxpayer or subsidized healthcare. In private hospitals, it's predominantly out-of-pocket health expenditure, which is actually close to 50% of India's total health expenditure. So much of the health expenditure is actually out-of-pocket, which has huge implications for obviously financial implications for families and patients. And there is insurance. Insurance penetration is increasing. I think 1/3 of the population is covered by some form of insurance, and insurance typically pays for inpatient costs. India launched something of an Obamacare equivalent a few years back, but much larger in scale. It's called Ayushman Bharat, which covers healthcare for certain socioeconomic groups in the country to a tune of 500,000 INR, and this covers both outpatient and inpatient costs. This has made an impact in terms of access to healthcare for a large proportion of people, but it's of course very much work in progress. Coming to intensive care itself, the first coronary care unit in India was established in the 1960s, and a respiratory ICU was set up in 1970s. But really, intensive care, as what you know here, would probably have started sometime in the mid-90s, when a lot of Indian doctors who trained in US, UK, Canada, and Australia started moving back to India and set up intensive care units in cities across India. The Indian Society of Critical Care Medicine was established in 1993. It's just turned 30 years this year. We have 17,000 members and 98 city chapters or branches. The first issue of the Indian Journal of Critical Care Medicine was published in 1997, but only got its impact factor very recently. The first training program started in 1998. India has 1-year and 2-year fellowship programs and a more comprehensive 3-year sort of a training program that started a couple of years back. Critical care was recognized as a distinct specialty in 2012. A little bit about capacity and resources. This is slightly older data. We published this paper, I think, around the beginning of the pandemic. I don't think a lot has changed. India was estimated to have 2.3 beds per 100,000 ICU beds per 100,000 population. I think in comparison, Australia, I'm told, has 9. Canada has something like 12, and Germany has 29 beds per 100,000 population. The total number of ICU doctors is unknown. The society has 17,000 members who all have some form of training, but there's, of course, more intensive care doctors than what the society has as its members. I just wanted to show this as an example of how difficult it is to get an ICU bed, right? As with most things in India, this is a survey from, I think sometime during the pandemic, people had to use, more than 40% had to use clout or pull strings to get an ICU bed. And most people had to sort of follow up extensively to get a bed, and it was really, really hard. I think you probably have seen news reports of people not getting beds, not getting oxygen, all of which is actually true. There have been several initiatives to increase capacity, and much of which was triggered by the pandemic. So many state governments and central governments have actually contributed to increase in ICU capacity. There's been an initiative called 10-bed ICU that's trying to create ICU beds in the rural sort of towns and district hospitals. And recently, India has launched this program called the Ayushman Bharat Health Infrastructure Scheme, which actually is specifically targeting building critical care capacity. But what we need to know is much of this capacity is actually being built in urban areas and sort of perpetuates existing health inequities. Okay, I'll move on to talking a little bit about the sort of patients' resources within the ICUs itself. This is a paper called the INDICAPS paper, which describes case mix and practice patterns. There was an INDICAPS 1, which was published, I think, in 2014 or 15. This is a more recent paper talking about intensive care case mix and patterns. This is a multi-center, 4-day cross-sectional study with data on over 4,600 patients from over 130 ICUs. But most of these ICUs were predominantly private and urban or semi-urban sort of ICUs. And as expected, or not surprisingly, in terms of access to X-ray, ABGs, ultrasonography, pretty good availability in these ICUs. Again, within the hospital itself, services, blood bank, microbiology, CT, all pretty good. But as I said, mostly urban, semi-urban ICUs. The model of intensive care in India is predominantly open ICUs. So as you can see here as well, 85% were open ICUs. And most of the ICUs involved in the study had some form of a training program. Who paid in these ICUs? Again, as I said, most of them were self-paying. Over 64% of the patients were paying out of pocket, and most of the admissions were medical admissions. This table here is a comparison of the INDICAPS 1 and INDICAPS 2 data. In terms of mortality, it was 13.5% in 2014. Average mortality is 15%. But there's a large proportion of patients in India that leave against medical advice because they run out of money. So this is called as discharge against medical advice or terminal discharge, who we expect will actually go out and die, unfortunately. So if you add all of that up, the mortality for the general critical care population is around 23%. In the last decade or so, we've actually seen a lot of sophisticated healthcare becoming available in India, especially in urban centers. So there's, you'll see papers talking about ECMO. You'll also see papers talking about, increasing number of liver transplants, heart and lung transplants, bone marrow transplants, robotic surgery, right? As per this paper, we were doing around 12,000 robotic surgeries a year, which we're probably doing more now. And India has sort of emerged as a hub for medical tourism because access to care is faster, and care is obviously cheaper in terms of at least US dollars. But this does highlight this dichotomy that we still have kids dying of diarrheal illnesses. There's lots of tuberculosis, but at the same time, there's lots of sophisticated care that's becoming available, at least in urban India, right? So there is this dichotomy, there is this contradiction, and there's a similar dichotomy, between the advances that we've been making in clinical medicine and research itself, right? You would expect that as health systems mature and as clinical practice sort of evolves and gets better, in parallel, the research ecosystem would pick up, but that's sort of not been the case. And these are some papers that, illustrate the point that our research output, this is not just critical care output, this is research output across Indian medical specialties, and our research output remains low, right? In this paper, they've sort of highlighted that only 4.3% of research institutions actually had more than 100 papers, and this is just talking about quantity, not about quality. In terms of where we are in the percentage share of papers, this is a scientometric analysis, again, a very small contribution to the global medical literature. You would think maybe in diseases where our burden is higher, our output would be better. Doesn't look like that. So this sort of looks at the percentage dailies lost, disability adjusted life years lost, and the amount of research or the research response. So if you take respiratory infections, for example, a lot of dailies lost, but our output is not really high there either, right? So this disconnect remains. This is a paper that compares output per million population and per billion GDP. This is India and Australia. So we have a per million number of clinical science papers is 2.22 in contrast to Australia's 196. So all of these facts sort of illustrating the fact that relative to our population and disease burden, our research output is low and often of low impact or quality. So specific to critical care, we wanted to explore what are the biggest barriers to doing critical care research, and we undertook the scoping review a few years back now, and sort of categorized into themes the barriers that emerge. The barriers, I guess, are obvious. The first one and the major one is financial. There's limited local funding for research in LMICs. This is true for other LMICs as well. We are often forced to depend on international grant funding, but because our output is low, our chance of success in grant funding are low. This creates this vicious cycle. Human capacity, this is a huge barrier, lack of access to mentors, lack of access to training programs, lack of access to statistical support, right? So all of these are big challenges. There's also challenges related to research infrastructure. This concept of research coordinators or formally trained coordinators, research associates, etc., doesn't formally exist in India. And even where they exist, they often go work for the industry. They don't really come to academia, right? And there's huge clinical burden, which I think is, of course, the biggest barrier to getting any research done. There is no dedicated time. So burden, clinical burden, funding, mentorship, all remain big challenges and barriers. The next thing that I want to talk about is the typical high-income country model of research, right, that you're all in this room very familiar with, is these programs of research that you develop with a 5 to 10-year vision. You take a disease area, you start with maybe a systematic review, identify gaps in knowledge, then you launch a survey, you want to find out what other clinicians are doing, where is equipoise, you then do an observational study, a pilot RCT, multi-center RCT, and then knowledge translation, right? So this is the typical model that the high-income country model of research involves. And this has very successfully been, I think, leveraged both by the Canadian Critical Care Trials Group and, of course, by the ANZICS CTG, and has inspired researchers around the world. But this model is very challenging to implement in India or in other LMICs, right, for several reasons. Specific to India, much of this high-quality tertiary intensive care is practiced in a very private, non-university segment of the healthcare system, where profit is the only motive, right? So research is sort of very, very low on the radar, and developing this sort of a model becomes very challenging. We don't have a formal clinician-scientist sort of a model in India. Even in academic centers of excellence, our existing critical care societies are really a network of clinicians and educators rather than researchers, right? And research and clinical medicine, therefore, sort of continue to be in silos with very limited interaction between the two. So if you take India, but also other LMICs, research becomes an individual endeavor with variable quality. Therefore, research output becomes restricted to a handful of academic critical care groups or departments. And the consequence of this is that our research is scattered, it's non-cohesive, right? Even when it's well-intentioned. There is duplication of research with multiple and small single-center, often low-quality studies, and a spawning of this whole Me Too literature. Nevertheless, despite all of these challenges, despite this sort of an ecosystem, a lot of good work has been happening, mostly driven by the society, but also by different research groups. There's been a lot of locally important research that's happened, and these are some examples. These are the INDICAPS 1 and 2 papers that generally describe case mix practice patterns. This is a study led by one of my colleagues in Chennai, looking at the observational study looking at the epidemiology and resistance pattern of common ICU infections, showing a huge burden of multi-drug resistant gram-negative infections. This is an important paper on tropical fevers. In this particular paper of over 400 patients, looking at patients that come with fever to an ICU, over 50% of them actually had a tropical infection, dengue, malaria, one of those. Sorry. This looked at what happens to patients that go against medical advice. As I said, over 50% or 60% die once they leave a hospital against medical advice. This is a paper looking at end-of-life care in India. So a lot of important papers coming out despite these challenges and despite the limited research support that exists. In the last, I would say, decade or so, there's also been this increasing need or awareness to collaborate internationally, and the pandemic, of course, accelerated this process. And you'll see some important papers that have come with key contributions from Indian investigators. I won't get into the studies themselves, but just to illustrate the fact that there are important international papers that have Indian investigators contributing in a big way. So the advantages of this sort of an international collaborative model is, of course, that patients from India and LMICs are represented. There's opportunity for researchers to collaborate, exchange ideas in India, learn, receive recognition and mentorship, and it builds research capacity, at least at the sites that are involved in these sort of projects. But there are also downsides, right? So we often end up as just being sites enrolling patients for a high-income country investigator. The research questions that they're asking may not always align with our own priorities, and there's really no real seat at the decision-making table. So there are some downsides to this model. I want to talk about some efforts that have happened in the last, again, 10 years or so, trying to build some local capacity. I'll first talk about things that I've been involved in, and then a bit about work that others are doing. So this is a critical care registry that we set up, very much inspired by ICNARC and ANZICS core, but sort of tailored to our local capacity and needs. So we started the Indian Registry of Intensive Care in 2019. It's a cloud-based registry focused on case mix and outcomes evaluation, quality improvement, and registry-enabled research. And we are part of a wider network of federated registries across Asia and Africa called the Critical Care Asia-Africa Network. We currently, I think, are in 18 countries in Asia and Africa put together. In India, we cover over 45 ICUs and 25 hospitals, which is, of course, a drop in the ocean as far as India is concerned, but has nevertheless progress. We've had over 70,000 patient encounters reported to the registry as of February 2024. This is sort of what our ICU report looks like, which any ICU can print off their platform. It gives data on their ICU in comparison to the whole registry. We also generate these sorts of funnel plots that I think you're very familiar with, talking about the SMR and where a particular unit falls with respect to other units. We have our own illness validation severity prediction system called eTropics, because Apache 2 is hard to do in India, or Apache 4 is even harder. We have used the registry's platform and infrastructure to enable and embed research. This has included both epidemiological research as well as trials. Some examples here. The REMAP CAP trial and MEGAROX trial in India run through the infrastructure that IRIS has created. I won't get into each of the papers, but just to illustrate the fact that the registry has served as a vehicle for research. This is Team IRIS from a recent meeting that we had just a couple of months back. Also, as part of our meetings, we try and build some capacity in terms of teaching research methodology. So last year at our meeting, we ran a datathon very similar to what you had yesterday. And this year, we ran something called a basic research workshop. So basic is this collaboration that I think you might be familiar with, basic clinical collaboration. They also have a research program led by, I think the program was developed by investigators from New Zealand and Canada. So we ran the first ever basic research workshop in India this year. So the next piece of work I want to talk about is collaboration between the George Institute for Global Health Australia, George Institute for Global Health India, and critical care researchers in the country. You'll see some familiar faces. Professor Bala Venkatesh and Dr. Naomi Hammond are very sort of fundamental to this collaboration. We started as a loose network, trying to do some sepsis work, and I think became a more formal network because of the impetus provided by the pandemic. Again, a couple of examples of work that this collaboration brought about. This was a trial that I led comparing, or evaluating hydroxychloroquine as a prophylactic agent for healthcare workers against the SARS-CoV-2 virus. We enrolled over 400 participants, completely locally run trial. Of course, we had mentorship from George Institute Australia. We had to stop early because of slow recruitment and commencement of vaccination, and of course, all the negative publicity that HCQ eventually received, right? And this project was actually funded by Wesley Medical Research Australia through Bala Venkatesh. This is the other piece of work I want to highlight, again, through the same collaboration. This is a trial that compared 2 doses of dexamethasone for patients with COVID-19 and severe hypoxemia. We enrolled close to 40% of the sample size in India across 12 centers. This is a collaboration between the Danish investigators, George Institute Australia, George Institute India, and of course researchers across the country. A secondary paper was led by the India team looking at heterogeneity of treatment effects for patients enrolled in India versus those enrolled in Europe, and I'll be talking a little bit about this tomorrow at one of the sessions. These are other groups that have similarly built local capacity and then done their own trials. This is actually one of the first convalescent plasma trials that was published during the pandemic, and it came from India, led by researchers from the Indian Council of Medical Research. Again, one of the earliest tocilizumab papers coming from a group in New Delhi. So also examples of locally led and executed trials. So these sort of collaborations resulted in a number of high-quality and high-impact projects. They established substantial research capacity at several centers across India. I think it also brought to mainstream this idea that we could do our own trials and do it successfully and do it with high quality. And I think it also provided a template for sort of equitable north-south models of collaboration. I'm running out of time, but I think I should be okay. I'll finish. These are some other initiatives. This is the ISCCM, which has started its own small grants for investigator-supported research, both for early career researchers, but also for trainees. Last couple of minutes, where should we go next? So I think we need to identify research priorities and develop answerable research questions locally. And again, there is some work going on. Our Critical Care Asia Africa Network, in partnership with the James Lind Alliance, is developing priorities for Indian critical care. We need to build on the collaborative partnerships that already exist and sort of expand to non-urban ICUs. We need to develop a cadre of clinician scientists, again, some work that's happening to do this, MD, PhD programs, build research capacity, which includes people and infrastructure. There are several known locally and already existing research priorities which remain unaddressed: tropical infections, infections caused by highly resistant gram-negative organisms, snakebite, toxicology. Most importantly, these are going to be unlikely that this will be on the radar of high-income research institutions or funders or government, so it's really upon us to take up these projects. I think the next big step on our research journey would be to build cohesive and coordinated programs of research tailored around these priorities. Fortunately, there are examples of this already. There's a couple of papers in the New England. This was a trial that evaluated the combination of doxycycline and azithromycin for severe scrub typhus coming from Christian Medical College in Vellore in southern India. This is burden of typhoid and paratyphoid fever. This is some work that we have just started, and I'll be talking about it on Friday, trying to plan a platform trial for dengue. So in summary, there's increase in access to intensive care across both urban and district hospitals in India. I think clinical practice and research still remain entrenched in silos. There are important barriers, but I think there is change, there is promise on the horizon. India's biggest moment in critical care research is yet to arrive, but I think will come only from investments in addressing local and urgent priorities. But most importantly, research in our country needs to become an integral part of the fabric of the healthcare system, and stakeholders need to be convinced and agree that research is a force for good. I'm going to stop there. A lot of people to thank, and I'm sure I missed a few here. But thank you so much again for this invitation and for this opportunity.